Hello, everyone. Welcome to another very special episode of HitCast, the official podcast of the Croatian Society of Emergency Medicine. It is evening here in beautiful Opatija, and I am so greatly honored to welcome a fellow, as we just found out, audio-video production aficionado, an ultrasound expert, Dr. Chris Yap from Sheffield, UK. Welcome, Chris.
Thank you. Thank you, Gigi.
Okay, so today Chris has agreed to talk to us about everything nerve blocks in the emergency department, and we are so very grateful to him that he's going to share his pearls of knowledge. So, for starters, Chris, what made you want to do nerve blocks in the ED, and how did it all start?
Well, as you know, as emergency medicine physicians or emergency doctors, we love to get our hands on things. And I think performing a nerve block is something that you can is a skill. And prior to the introduction of ultrasound, I was already performing nerve blocks anyway with what we call the blind technique. So, for example, sometimes even for the supraorbital nerve block, I will still do that without ultrasound. And I used to do dental blocks, etc. And then I started off learning just normal, the normal POCUS first, like the fast scan, echo and life support, vascular access. And then slowly we realized that patients with hip fractures was an for my hospital where I work, we have about 2.1 to 2.2 patients a day. So that's a significant number. And I thought that taking the pain away early and quickly was important. That was one of the motivations for us to learn.
That's great. And I guess a common story around the EM folks who take up nerve blocks, like you said, take away the pain right now with great efficiency, maybe greater than any analgesic that we can give. So, when you started out, what were your first blocks using ultrasound? What did you focus on? And how did you choose? Like, there's a bunch of nerve blocks. How did you choose, okay, I want to master these ones, these are important to me, and what were those initial blocks?
I think I need to give a credit to one of my colleagues. He was a colleague with me in Barnsley, and he was the one that initiated it actually. And but as I think for each hospital, it may be different because it depends on your patient population, and you need to look at which blocks offer the highest value to your patients, which are the commonest presentations in your hospital. So say, for example, if all the hip fractures in your region go to a different hospital, then you may never see a hip fracture, or you may only see it once in a while. But every single wrist fracture comes to you, then you may have to think about the blocks rather than a hip fracture blocks. For us, um, it's also partly, I think, there is a net in the UK. There's a national hip fracture database, and part of that database or the metrics, good quality and good quality care, is the patient having some form of pre-operative block. And that was part of the driver of why we introduced the um, fascia islet block for our patients. So now in our ED, um, about 85% or higher, hopefully higher, patients with neck or femur fractures or hip fractures come into our emergency department, they have some form of a fascia islet block. It might be an infrainguinal or a suprainguinal fascia islet block.
That's so awesome. That's a huge number of people receiving adequate pain relief, and I'm so happy to hear that. So, can you tell me when starting out for centers that are like somewhere in the middle? So, people doing POCUS regularly, people being good at POCUS, but still not, taking the needle up. Uh, how difficult it is to implement nerve blocks in everyday practice, and what are some of the main barriers that you see people face when trying to start a nerve block program in their ED from zero?
I think the most common thing I hear now from colleagues around the world when they try to introduce nerve blocks in the ED is resistance from other specialty colleagues. So the most important thing for me is that you need to get buy-in from your anesthetic colleagues and your orthopedic colleagues if it's related to with fractures, um, because the anaesthetists or the regional anaesthetists are the experts in performing blocks. And if you want to learn any particular kind of block, then I would often recommend that you spend time with a regional anaesthetist, and they can help support your training. And in parts of the UK, we are blessed with quite a number of regional anaesthetists who do support our department. So in my hospital, we are supported by that. But but I also know that in some EDs, um, n- the ED physicians don't perform the blocks at the moment. So the first thing, as I said, is buy-in from the regional anaesthetist and the orthopedic doctors, because if you are wanting to learn a block, then probably you might either have to go to theatre to spend time with the regional anaesthetist, or you may need the regional anaesthetist to come down to you to show you or supervise you if you're performing your blocks early on. So that's the first thing in terms of getting when people try to introduce the program is to get buy-in. Um, there is also the factor of kudos. Are you able to do this? And so I think for you, if you really want to introduce regional anesthesia, then you need to sort out your needling technique. Because if you want to spend time in theatre, then you want to be blocking the nerve or the fascia that you're wanting to block. And if the anaesthetist is having to use up time trying to correct your technique, you are wasting their time. You're delaying the start of the operation. So I think as an emergency medicine physician, you need to start learning to handle the probe in your non-dominant hand, learning to anchor your probe and how you hold the needle. We give a whole talk over 20 minutes to half an hour about needling technique. Maybe I'll do a Instagram post about it.
I would love to see it. And how do you make people practice needling? Do you have some specific phantom models, some DIY models?
So it's a work in progress.
Mhm.
In the early days, you can use tofu, or you can buy gel phantoms. You can because ultimately the skill is is similar to a vascular access. So if you know how to make a vascular access model, then it's the same kind of principles as I mentioned about anchoring and holding the needle, having the machine in front of you, make sure your body is in a straight line from your head, each hand, your hand holding probe, the hand holding the needle, your eyes and the screen in front of you. Everything needs to be in line. And so that technique is, and you can practice that on a gel phantom. But for I'm discovering, it's still a work in progress for me, and we are trying to create as realistic a phantom as we can. There's this term called haptic feedback. Is when you put a needle in, you want that feedback of when you're going through fascia or you're going through muscle. And the great thing about using meat models, like you can buy chicken or you can buy pork or beef or lamb, is that they tend not to leave scars. But there isn't much longevity with meat models, so it might last 1 or 2 days, or if you could freeze it, but then once you thaw it, then you can only use it one more time. With gel phantoms, you can reuse them, but the gel phantoms tend to leave scars, so they're not perfect. And with gel phantoms, you tend to need to turn up the gain on your computer, and on your on your ultrasound. With gel phantoms, you tend to need to turn up the gain on the ultrasound machine, and as a result, your needle is much brighter and much easier to see on the ultrasound machine. So it's not as realistic as a meat model. Uh, we we are doing the podcast now during the Congress, and just before the Congress, we had a course on nerve blocks, and we practiced that on meat models which we created, and you could see that sometimes if your probe is off and wasn't in line with the needle, you couldn't see the needle. So it's not as forgiving as a gel phantom. So I'm very much now, and it might change in 6 months, it might change in 12 months as I experiment more. But for now, I'm really keen that if I conduct any future courses, that if I can introduce a meat model, bring it in. If the venue allows me to, I will do that.
Thanks for the very detailed answer.
I hope it's not too
It's
detailed.
really it is detailed, and I'm happy because people listening to this who might think, oh, my needling needs work, now have specific guidance on what to get, what to use, why not to use this, why use that. And maybe the most important part is she said maybe you don't need a gel phantom that costs, I don't know, a few hundred euros. Maybe you just need a piece of meat from the local
Yeah.
butcher.
I mean, gel phantoms are very expensive. They're four, five, 600 pounds. Sorry, yeah, 450, 550, 650 euros or more. And I think just like your podcast, just like how you're trying to buy better equipment, more equipment to make it better. You know, we've had a great chat even before we went on air, and we enjoyed the chat because we are trying to make things better. We had that mindset, and I think for me, as a Focus user, I want to um, enhance a learner's experience. And if I can bring it as close to reality, then that's what, and I'm always trying to seek to make it better. I think that's what drives me. Yeah, it does.
Wonderful. And regarding learners, now that we mentioned them, uh, is regional anesthesia part of the core curriculum of emergency medicine in the UK? Or is it, let's say, like a super skill that you are very enthusiastic about and want to teach people?
So the fascia eyelid block for hip fractures,
Hmm.
whether it's the infrainguinal block or the suprainguinal block, is part of the curriculum. There aren't any blocks besides that at the moment as part of the curriculum. So the curriculum, if we need to revise it, is a big process to do that. So at the moment, it's just the fascia eyelid block because we recognize in the UK that neck of femur fractures is a big thing. But pain is a big thing in the emergency department, and patients may come with pain because they've broken something. And so I think um, my I would like to introduce other forms of blocks, and that's why we have but that's why we've created a course, I think, to introduce blocks that I think are of the highest value for emergency department patients. In the UK, there's an organization called Regional Anesthesia UK, and they have developed a program for the anesthetic trainees, where there is what they call Plan A blocks. So blocks that every anesthetist, whether you are a regional anesthetist or not, should be able to do. And that's an excellent list of blocks for anesthetists. But not all, in my opinion, this is my opinion. Sorry for touching the mic. In my opinion, not all the blocks on the Plan A list are relevant for the ED. So we need to probably think about creating um, a new uh, a new list for the ED.
Makes sense.
So watch this space. Yeah.
Yeah. And when you teach your trainees, your learners, I know it's very individual, it's very, the skill varies, the affinity varies, and so on. But how many, let's say, repetitions of a single block, a simple plan A block, do you think they need in order to be independently performing it while you're being quite safe that they're hitting what they need to hit and not hitting what they should not hit?
It's interesting you come to that point, but this applies to all forms of competency, all forms of ultrasound skills. Is there a minimum? Is there a minimum number of scans that one should perform? Is there a minimum number of blocks that one should perform? Um, there isn't in most literature. If you do a big literature search, I think they recommend about between 20, maybe sometimes even up to 40 scans of a certain skill. But some people may achieve that much earlier, achieve the competency much earlier. So I think it's up to the learner to decide when to initiate an assessment of the skills. Um, so I so I think it's up to your local group or your local policy to decide what the minimum number of scans are. But in general, usually we say about 40. Sometimes some people say up to 50 blocks. Yeah, before you deem, on your logbook at least. Yeah.
Great. It's a start. It's a pointer in the
Yeah.
general
Yeah.
direction, and I like it.
And there's some in the literature that may say 20 or 30. So, you can see that there's a big range between 20 to 50. And because everybody learns at a different speed, everybody's psychomotor skills are slightly different. Some of us enjoy it um, um, practical procedures more than others. And for the record, I do not do any gaming because that people often wonder if for people who do enjoy regional anesthesia whether we are good gamers because somehow our psychomotor skills are good. But I am absolutely not a gamer. I get car sick and seasick whenever I play online games.
Good to
Sorry,
know.
I wanted to break that myth.
I mean, I am a gamer, but I don't do regional. So
Yeah,
if I take it up, I'll be sure to send you an email in a few months. Like,
you
did
know, you
yeah,
struggle or not.
I am happy to announce that no, my gaming skills unfortunately did not translate into yet another skill.
It might be a good study. It might be a good
Right?
study to conduct. Yeah.
Yeah, we might do some collaboration.
Yeah. Well, we have chatted about that offline, haven't we? So,
Okay, yeah. So next question is about the practically logistical aspects. So yes, we said every block depends on the hospital, on the institution, what kind of patients you see, and so on. But let's say in your center, which of the blocks do you find the most value in, the most, let's say, uh, cost benefits ratio on the side of benefits mostly? So, which are the blocks you find invaluable in your daily practice, just from your perspective?
so I work in the UK in the NHS, and I gather and I think I understand that the NHS system or the health system in Croatia is very similar to the NHS, where the patient who arrives, they do not have to think about health insurance, and we give the same care whoever you are, whatever
Yeah.
background you have. So to me, the benefit is for patients, especially the elderly patients, is the decrease in opioid use because opioids has its complications, and if you're elderly, then there's an increased risk of delirium. There's an increased risk of respiratory depression and pain. If you don't sort out the pain early, then for any patient, then the risk of chronic pain goes up. So blocks try to reduce that level of pain. USAM has created come up with a recent uh, pain guidelines that you should all read about. It's been one of the authors is our current president, USAM, Robert Leach, and blocks is part of that method of reducing pain. And I think it's important to understand that blocks is not the only thing. Is the patient may still need other forms of analgesia. And so there's this important concept of MMA, not mixed martial arts, but multimodal analgesia. So even though you've given a block, you should still prescribe your painkillers for your patient because your block can still fail. So in terms of what kind of blocks are going to be useful or what you should for your patients, as I mentioned, you need to work out for your department or for your ED that you're practicing in. You can just do a survey. You can pull out the information from your records. What are the commonest fractures? And then you can review and think, okay, could these fractures or these injuries be relieved by some form of block? So right now we are introducing uh, blocks for chest wall injuries, patients with rib fractures. So there's the serratus anterior plane block or the erector spinal plane block, ESP, or the SAP. Um, the SAP, the serratus anterior plane block, is much easier to learn because as emergency physicians, we're really quite used to doing lung ultrasound. So we recognize what the lung looks like. We recognize what ribs look like. And so now all we need to do is make sure our needling is good and sound. And we can decide then for ourselves whether we do the SAP block uh, with the deep approach where the needle touches the rib or the superficial approach where the needle's in between the latissimus dorsi and the serratus anterior muscle. The ESP block, the erector spinal plane block, is a lot more difficult technically, and also trying to keep your needling technique needs to be um, needs to be really good, needs to be really sound, because it's the when you're trying to find the transverse process with the ESP block, um, it's very easy to lose sight of the needle. That's where you definitely need assistance or help from the regional anaesthetist when you're performing the block. Because if you want to learn that block, I would say you need a regional anaesthetist to help you, and you go to spend time with them in theaters with the ESP block. But the ESP block is effective for all forms of rib fractures for posterior, lateral, and anterior. Whereas the SAP block is mainly for patients with lateral and anterior rib fractures. Then you can think about, so that's for chest wall injury. Then you can think about for the upper limb, what are our most common injuries? So wrist fractures, Colles fractures, and maybe shoulder dislocations. So with wrist fractures, you could consider doing a forearm block, a block of the median nerve and the radial nerve, maybe the ulnar nerve as well. And that is actually probably one of the easier blocks to learn to start off with. With the shoulder, that is trickier because then you're going towards the brachial plexus. And I think if you are a learner and you're just starting out, then I would say for that, stay away from the neck region for now, because there's every chance of you spreading the local anesthetic to the phrenic nerve. And you need to have the backup of a backup plan. You need to have a protocol. You need to have clear guidelines of what you do if you were to do a brachial plexus block from the neck, cervical plexus. So I think if you are a learner, then if you look at any program that we run, we tend to teach forearm blocks. We teach this chest wall blocks. We teach the fascia eyelid block, and then slightly like a bit more skill is we teach the popliteal sciatic block for patients with tibial fractures. Um, but again, the tibial fracture is always tricky because that's high impact trauma. So with high impact trauma, there is that theoretical risk of compartment syndrome. And so we have guidance in the UK from the Association of Anaesthetists called AAGBI, that association, where if you want to perform a block like the popliteal sciatic block, you should have discussion with the orthopedic surgeons about whether they are happy for you to perform the block. Yeah, so I'll summarize again. I think the first blocks you need to find out is what will be most effective for your local population. In my department would be hip fractures, uh, rib fractures, and then wrist fractures, and then after that would be ankle and tibia fractures.
Sounds great. Thank you for the general pointer, and I think a lot of people are going to get a basic orientation and maybe have at least some kind of part marked out for them, like, okay, yeah, so he said this, okay, I want to learn this. And I think maybe when starting out, the most important thing is knowing what options are available and which ones you should pursue. So thank you so very much for that
You're
feedback.
welcome.
Now, another concept, block trolley.
Okay.
So I love your Instagram post about the block trolley, and I would like you, if you want, to present a short elevator pitch in like 2 or 3 minutes of the block trolley and explain why it's so good and why maybe I should get one if I start doing blocks.
I mean, yeah, I suppose I'm doing a shout out for my own Instagram page, but we've been thinking about it for a while, and then one of our residents came up, was keen to do it as part of her QIP, her quality improvement
Hmm.
project. But at the same time, we didn't want to spend too much money on it. Um, in the ED, our workload is tremendous, and if you can reduce the cognitive load for anything, any procedure, or anything we do, especially like code red trauma, like serious trauma, anything you can take away the cognitive load is always a bonus, and that's the concept of the lock trolley. So we managed to go to the hospital stores because I was trying to save money, and we asked them whether they had any spare trolleys, and they had two unused trolleys. So we started off with two very dirty, unwanted trolleys, and my fellows cleaned it up and uh, tidied it all up, and we decided what we needed in the block trolley itself. So right on the top where we put all our kit is what I call a shadow board, and that on that shadow board it tells you what things you need to place on the top of the trolley. So again, that's taking off the cognitive load, and on it as well is the calculation for the intralipid, because when things go wrong, if the patient were to have a local anesthetic systemic toxicity, the last thing you want is try to work it out in your brain or remember what the concentration is. So we have the milligram per kilogram dose. And so I encourage anyone who does a block to write it on the board wherever they are or write it on a piece of paper. So we've got that. And as I said, it's got like an outline of things that you need to put there so that you're ready to perform a block. And basically everything that's on top of that is most of them will be in the drawers. So we have a block pack, we have needles, we have drawing needles, we have sterile gel, we have a probe cover. But the block pack that we use, there are some things that we don't need at the moment. So that's put aside in one of the drawers as well. And I apologize, that's more than 2 minutes.
No, it's perfect. And the reason why I asked is because I loved it at first sight. Because, like you said, I saw something that takes away the entire cognitive load and completely makes it automatic for you. Like, take this out from here, this out from here, put it on here. It makes the entire process so much easier to do, not only once, but reproduce every time, because the entire preparation part, you don't need it.
Yeah.
You don't think about it. You just take what's available. And it's such great design philosophy. I fell in love, and you should all see Dr. Yap's block trolley. So, to wrap it all up, maybe 2 or 3 take-home messages for the folks wanting to do regional anesthesia or nerve blocks in the ED, what they should focus on, and what their first steps should be, and maybe what to look out for.
Okay. So firstly, you need to get your needling techniques down. How you hold your probe um, uh, when you're doing vascular access is a reflection of how you're going to do your needling for a nerve block or a fascial element block. So I think that's the first thing. And I hope you don't mind, I repeat myself. I often say as you hold your probe, make sure the probe is flush with the outer border of your hand, of your non-dominant hand, so that when you're resting it on the patient, you're not holding the probe up here, because when there's lots of gel, your probe's going to slip. So you anchor your hand and you raise the bed or you sit down so that your arms are nice and relaxed. And everything needs to be in line. Your head, eyes, both hands, so your needle, your probe holding hand, patients there, where you're going to block, and the screen should be opposite, everything in one line. That's the first thing. Then the next things is, I hope I remember it in order, but I'm going to quote a good friend of mine. He's a regional anaesthetist based in Sheffield. He's called Steve Rowe, and he always talks about you need to know the nerve. So you need to know what you're blocking, the nerve you're blocking. You need to know the muscles around it or the structures around it so that you know what you're looking at. You need to know the nerve. You need to be able to see the nerve. So you need to understand when you put the probe on, what you should expect from the sonoanatomy. So when you put a probe on, if this is what this lumpy bit is this a nerve? Is this a fascia? So you need to know the nerve. You need to be able to see the nerve. Third is you need to be able to see the needle, and that's going back to the needling technique. And lastly, do the block. And to do the block, you need to practice, and to get practice, you need someone to supervise you. So find a friendly regional anaesthetist who will support you. It's probably the biggest challenge.
Thank you very much. This was an awesome podcast full of interesting tidbits and pearls. And I'm sure everyone listening and watching will get something out of this. And I'm sure a lot of people are going to fall in love with regional anesthesia. Maybe some will start doing it. Thank you for being such an inspiration. Thank you for being a guest. And see you next time.
Thank you.
Have a great conference.